Yes.
Dr. Giangrande, I'm going to ask you to look, first of all, at a passage in your statement with me. Seamus, it's WITN 3311003. And if we could go to page 85. No, that's page 85. Oh, I'm so sorry. Try page 35, Seamus. My apologies.
What's the paragraph number?
It's paragraph 83.
Thank
you. If we go to the next page, please, Seamus. Sorry, I have an unpaginated copy. So. That's it. Thank you. So if we go to the bottom of the half of the page, please. So, Dr. Giangrande, you'll see you were asked about how the care and treatment of patients with HIV and AIDS was managed at the Westminster Hospital and the Oxford Centre. And in 83.1, you've said in relation to the Westminster Hospital you've no information. Is this correct that you were not involved in the care of any patients with HIV or AIDS at Westminster?
Absolutely right. That's correct.
And then in relation to Oxford, you say patients would have been referred for specialist advice and follow-up. We'll come back to hepatology and hepatitis separately. Follow-up to an infectious diseases expert. And then you were asked about what treatment options were offered over the years to those infected with HIV, and you said the care would have been provided by the infectious diseases team. And then if we go to the top of the next page, you were asked what information was provided about risks and benefits of specific treatments and side effects, and you said that these treatments were only provided by the infectious diseases team, and the same answer in relation to follow-up and ongoing monitoring. Now, Dr. Giangrande, would you accept those answers give the impression that you didn't have any involvement yourself with the care and treatment of the patients with HIV at Oxford?
I'm sorry if that's the impression that's given. Indeed, I thought I had made clear in the earlier session before coffee that I indeed set up the collaboration between the infectious diseases team and the Haemophilia Centre, and we were, of course, neighbours. So I'm sorry if that's the impression that's been given. What I'm trying to say is, although I was closely involved and indeed attended joint clinics, at least for the first few years that the combined clinics operated, the decisions about treatment were very much in the hands of the infectious diseases team. And indeed, I'd go as far as to say, I can remember one or two occasions actually when we've tried to modify things that the infectious diseases team has had when they were not happy. So let's be clear, I was involved in the follow-up, having set it up. But the decisions about treatment, in other words, was I involved in any decisions about which antiretroviral agent to use, clinical trials to participate in, did a patient need admission and certain treatment? That was not my link. We've got to be clear about that. That was not my role. That was the prime role of the infectious diseases team, who were right next door to us and with whom we had very good and close collaboration. I hope that's clarified that.
And I just want to look at...
well, we just pause for a moment. We are asking about the top of the page, are we? C, what information was provided to patients about the risks and benefits.
Yeah.
But you were present at the consultation, as I understand it, when you first started, because you set up the joint consultations.
Yeah. Yes, I would have been involved in those consultations. Yes, that's certainly true.
So you would have heard the information that was provided then to those patients?
Yes.
And
I'm sorry if I...
that, insofar as information was given to the patient about risks and benefits of treatment, that isn't a treatment decision, because the treatment decision presumably is reached jointly by patient and doctor. The patient is participant in it.
I see your point, and I fully accept your point.
So was there a reason why you said you weren't able to answer that question?
I think what I was, in other words, I was certainly involved in the clinics at the very early stage. So in other words, I set the clinics up as soon as I arrived in Oxford in April '91. And then I remained running the combined clinics with the infectious diseases people until, if I had to guess, probably 95, that sort of period. At that stage, the combined clinics, I was not attending them for the simple reason that then the patients with haemophilia there were patients with other HIV triggered by other things, and therefore I did not attend the clinics because the patients with haemophilia only formed a minority. So I guess what I'm trying to say is, looking back at a period lasting till 2015, it's true to say I was in the clinics in the very early years, but when the more complicated treatments became available, for instance, heart, which became available in around 96, going from memory, I was not involved in that stage. But I quite accept that at the beginning, I was present and I would have discussed some of the then basic and initial treatments for HIV. But I was not, for most of the time that I was working in Oxford. Most of the time, the patients were followed up just by the infectious diseases team.
Thank you.
And I just want to look at one document. It's from patient records, but I'm not going to be asking you about the specific patient. It's just to see how, in practice, the clinics operated. So could we have JEVA 5013, please, Shomek? So it's slightly faint. We can see it's a letter from you, May 1991, so not long after you'd arrived in Oxford, about a particular patient. And if we go further down the page, second main paragraph, it says, we've taken the opportunity to review the patient's general condition. And then there's a discussion about...
Can I just raise the name of the patient appears to be there?
Yes, that's with the consent of the patient's relative.
Consent. Thank you.
Yes. It's not intended to be anonymous, but I'm not going to ask you about the specific care of the individual. So we can see that in the main paragraph, second main paragraph, there's a reference to reviewing the condition to CD4 counts, and then a decision. We decided to start treatment with cotrim. Well, that's Septrin, isn't it? I think we can see there.
It is. Yes.
And it said that it'll be permanent treatment. And then if we go on to the second page, so this is picking up in 1993. So this is approximately 2 years later, and this is a letter to Dr. Conlon. So this is now the infectious disease specialist, is it?
Mm-hmm. Yes.
And then we can see reference to a combined clinic, reference to the full blood count, a decrease in white cell count likely to be due to the Septrin therapy, and a suggestion that the patient stop taking Septrin. So I don't know whether those documents assist generally in trying to give a clearer indication of the timeline here. In May of 1991, the first document we looked at, there's no reference there to a joint clinic, and it looks like the letter you're writing is to the GP. So is it fair to infer that it's only a month or so after you've arrived, there was at that point no joint clinic?
I think that is probably the case, but equally, again, it's very difficult for me to see these and give a definitive answer in the absence of seeing any clinical notes. But I think looking at the previous letter, how I would respond is to say that an agreement had already been reached on a general principle of treatment, and that is, as prophylaxis against pneumocystis pneumonia, it was general practice to start the treatment with Septrin once the CD4 count had fallen below 0.2 times 10 to the 9 per litre. And that would have been like general advice from the infectious diseases team. And I would make that decision without having to consult specifically an infectious diseases colleague about that. That's a general decision, a policy that's been made. As you rightly point out, that letter was written, that will have been the first time that I had met Mr. Evans, whom I remember very well, and his wife actually. It would have been the first time I'd seen him, and what the letter shows is that he'd come in, I think, he was on an orthopedic ward for whatever reason, and I had picked up and acted on the fact that the CD4 count was low. Presumably, the last count had been done probably 6 months before then, because that was the fairly standard thing. And we therefore started the treatment at an early opportunity. Chris Conlon was indeed the consultant that was taken on. I hadn't realized it was as early as 1993, actually, but anyway, he took over the running of the combined clinics from Dr. Lutzi. And looking at this, I can see that we'd obviously recently reviewed him on our combined clinic. I had received the full blood count, and indeed the white count is low. And we had attributed this to the Sectrin, which is a known side effect of the drug. And clearly he was going to be reviewed in our next combined clinic. And if Chris Conlon wanted to make any alternative suggestions for treatment in the meantime, this was giving him an opportunity to let me know about alternative therapies he may wish to offer.
So we can infer, I think from this, that between May 1991 and July 1993, the joint clinics were set up.
Yes, I can't. It was something. It started fairly soon. That I can say, but I can't remember when. I mean, certainly they will have been set up sometime in 1991.
And was Sectrin as a treatment already in use in Oxford by the time you arrived?
I think it was, because the previous treatment which I'd come across, I think they had it at the Royal Free at the time, was inhaled pentamidine was used by inhalation as a preventative measure, but Sectrin had become a standard therapy. So I think the answer to that must be yes.
And the reference to the combined clinic in this letter is to the joint clinics with Dr. Conlon. And as I understand your earlier answers, you think that the joint clinics came to an end sometime in the mid-1990s?
Yes, and I say why they came to, it's a bit like our orthopedic clinic actually, but that's a separate story, but as regards the HIV clinic, what happened was the people seen in the clinic that I set up originally were exclusively people with haemophilia. And in contrast to other cities, certainly London, people from other risk categories were never seen in this combined clinic. There wasn't the demand. There was a genitourinary department down at the Radcliffe Infirmary that saw a few patients. But the decision was then taken to unify everything up on the Churchill site. And that was certainly, I would guess, certainly by 96, probably 1995. And this was when the more complex therapies came into being. And so just to clarify, those were the decisions that I was not involved with. I was in on the combined clinics in the relatively early days. And I think having set it up, it worked very well under the auspices of the infectious diseases team alone.
And so just in terms of how patients would receive their care once the joint clinics had ceased to operate, whenever precisely that was, a patient would then have an appointment with the Haemophilia Centre, at least if they were a severe patient requiring their regular outpatient reviews, but would have a separate appointment with the infectious diseases unit that would be managed by the infectious diseases unit. Is that correct?
It is correct, but I'd want to expand on that and to say there was extremely close collaboration between the two. I emphasize they were neighbours of ours, and we had very good working links with them. So it's not that we corresponded simply by letter, as one might infer from these two letters you're showing here. We had regular meetings between the two teams to discuss the patients. And furthermore, there was the social worker that I told you who stayed till the end of the 1990s. She was very much a link between the two. What we tried to do, just as happened for the hepatology clinics, is if a patient came to see the infectious diseases team, we would try to set up the follow-up, if it was needed, in the haemophilia centre right next door. And then we would actually take all the bloods. So what would happen is they would come to us from John Ware and Ward, and they'd have filled in forms. We would do the follow-up, and the bloods would be taken. But it's important to emphasise there was very good collaboration between the two departments. We discussed the patients at regular meetings, so we both knew what was going on.
Now I want to move next to hepatitis C testing at the Haemophilia Centre. And I'm going to ask for your statement to go back on screen because I think there's one part of your statement you want to correct.
Yes.
So could we have WITN 3311003? And could we go, please, Shimk, it's probably page 30 or thereabouts, paragraph 68. So if we go on one more page. So am I right in understanding it's paragraph 68 that you want to correct?
No, that was the one that was, that is the one that's been corrected. But the two I highlighted when we had our previous exchange were paragraphs 73.1 and 77.1. And this was entirely an error of mine in copying and pasting, I'm afraid, which I noted only after this had gone in.
So we'll just go. Sorry, I'll just stop you there, Dr. Giangrande, just so that we can follow. We'll go to the relevant paragraph. So if you could go on 2 pages, please, Shomik. So we've got 73.1.
Okay, so the mistake is there in line 3, and I'd done that and I had inadvertently, it clashes with what was said before. I said HIV, obviously, by the time I arrived, people had been informed of the diagnosis as well as being tested. The incorrect statement is in line 3, where I said that patients infected with HCV had been informed of the diagnosis. That is not correct. And the same error appears because it was cut and pasted in 77.1. So people had been tested, but they had not been informed of the diagnosis.
So we'll look in a moment at your evidence to the Lindsay Tribunal, which obviously was given closer in time to the events than now. But before we do that, what can you recall about the arrangements for the testing of patients for hepatitis C in Oxford from your arrival in April 1991 onwards?
Okay. Again, I must preface this by saying clearly I have no reference to notes now, and I've not seen any statements that have been produced that may have been produced by, for instance, Dr. Ritzer or Dr. Trowell. So I'm going from memory. I think it's fair to say when I arrived from Milan, all the patients in Milan had been tested and informed of their diagnosis. In fact, Professor Mannucci published the results of the Milan cohort in the Annals of Internal Medicine on the 1st of March 1990, and he found that 82% of the 236 patients had tested positive for HCV. And furthermore, the Italian Blood Transfusion Service had introduced screening of blood donors sometime in 1990. When I came to Oxford in 1991, I was aware that after an absence of professionally of 15 months in the UK, I was a little bit surprised to see that screening of blood donors had not started here. I was aware that patients at the Oxford Haemophilia Centre had been tested for HCV because I could see in the back of the clinical notes there were flowcharts this was a day before computerized records. And I took over from Dr. Matthews the role of completing those flowcharts. So I saw that patients had been tested before I arrived. I note in the Lindsay Tribunal I stated a start date of October of 1990. That's what I said then, and I don't know, I can't add to that. My belief is that that was done, I say this now, in retrospect, I think on tested samples. I did follow the presentation you gave on October the 9th about the Oxford Haemophilia Centre, and I have to say I was surprised at the number of patients that appear to have been tested. If you'd asked me to guess beforehand, I would have thought it was less than that, but it seems from the presentation you gave that around 400 patients were tested. Now, my recollection is that patients were not informed of the diagnosis then. I believe there were two issues. The first is that the blood transfusion service, and therefore presumably the virologists, were wanting to set up the second generation assays, which were undoubtedly more reliable. The second issue was also, I think Dr. Ritzer was not clear about what the implications of a positive result were. So what I remember is that a patient started to be tested again using, I believe, fresh samples some months after I arrived in Oxford, and I would see results come back saying HCV study. And informing patients of those results began in probably the second half of 1991. There was also another important component to this, and that is very specifically a study of the risk of sexual transmission of hepatitis C. And for this, a study was set up analysing 104 men with HIV, actually they were not all men, I think there were one or two women with von Willebrand disease, but 104 patients with bleeding disorders, the vast majority of whom were people with haemophilia, and their partners, their long-term partners. The results of that study were published in 1993, well into 1993. Now, I was not involved in that study. I was not involved in any discussions relating to that study either, and absolutely appropriately, therefore, I was not included as a co-author. The named co-authors from the Oxford Haemophilia Centre were Charles Ritzer, Mary Fletcher, and then there was another nurse who was acknowledged as having helped collect the blood samples. Now, the point about that is, and it'll relate to the question of consent, where patients, I had always assumed that consent had been forthcoming, particularly for the study of sexual transmission, because I made the assumption, which I don't think was unreasonable, that to carry out a survey of 104 people, and their partners, how do you tell them, oh, next time you come to the clinic, bring your wife, or go to their home to take a blood sample? If my wife accompanied me to a hospital appointment and someone said, oh, could you please take a blood, could we have a blood sample from you? I can tell you she would not just proffer her arm and ask for blood to be taken. So just continuing the story, so I know, having reviewed that paper again recently, that although it was published in 1993, it was accepted in November. So if we go back from then, probably the blood collection stopped, it was complete by the summer of 92. And we know from the paper that most of the bloods were taken in 1991 and 1992. It says that very clearly. That study was helpful in two ways, because it included PCR results, and it provided evidence that not everybody with a positive anti-HCV result had indeed got chronic infection. And I'd contrast that with the Milan situation, because I remember well from the discussions there, and Manucci implies it very strongly in his 1990 article, that a positive HCV result means you've definitely got chronic infection. In fact, Dr. Ritzer was more cautious, and I think he was proved right in that the PCR results showed that the majority, but not all, people with HCV antibody positive results were chronically infected. And of course, the second major contribution of that study was it showed the risk of sexual transmission to long-term partners was low. And again, if I may just carry on, I think that the majority of the patients were informed of their results by the end of 1993. One of the things I did after Dr. Ritzer announced his retirement, he gave me about 3 months' notice, so he just said, Paul, I'll be going, is I introduced a checklist for hepatitis C because many of the patients had been told their results by other people. So either Dr. Ritzer, who I think, because of his long association with the patients, wanted to tell people, and certainly Dr. Trowell was involved. So I, faced with the prospect of taking over this cohort, large cohort of infected patients, devised a checklist. And the checklist went in the notes, and it was a record for us all. And the checklist was as follows. It said name of the patient, date, and then it would say, what I've discussed the following with the patient: the current HCV results, current liver function tests, follow-up arrangements, the synergistic effect of alcohol, in other words, cut down on alcohol, risk of sexual transmission, and treatment options. And then at the bottom it said patient was or was not aware of this result. Now, I know that quite a few of the patients that I saw towards the end of 1993 had still not, well, apparently they told me they had not got their results, but I think the vast majority had been told their results by the end of 1993. And it's a very long story, but I think I will have to revisit the question of consent, because I had assumed that consent had been forthcoming. But I'm not going to contradict anyone, and I have read the witness statements not only of Oxford patients, whom I'm pleased to say are a few in number on the IBI website, but others as well, and I'm by no means confident that consent was obtained in all cases. Sorry, it's a very long answer.
No, that's fine, Dr. Giangrande. Can I just break it down to check I've correctly understood? So your understanding is that by the time you arrived in April 1991, there had been testing of patients for hepatitis C, but it had been done on the basis, you think, of stored samples.
I have no doubt about that. That's my clear impression. And that would be the first generation assay.
And then in the period of time that followed from your arrival to around the end of 1993, there was a second round of testing. Would it have been a first round for some patients, do you think?
Well, I say it was very helpful for me to read the transcript and indeed some of the letters that you had included in the presentation on the Oxford Haemophilia Centre, because those are letters, as I'm sure you saw, I was not copied into, and I was not present at some of the meetings that clearly took place with the virologists. But it was a large number of patients. I was surprised at the number. It was over, I've got it written down, about 400 patients who'd been tested. So mainly haemophilia and a small number with von Willebrand's disease. So I think people were retested, or in some cases tested for the first time on fresh samples. And not all of those, I mean, the PCR testing really came in towards the bottom end of the, I think probably 1992 I began to see results of that.
And in relation to the testing on fresh samples, what is your best understanding of the information that was given to patients about the purpose for taking the samples?
Well, that is where I now have my doubts, because very clearly there was a formal HCV study. I saw that on the results that came back, and I had seen it in notes as well. So one of the nurses that go out there put HCV study, and there was nothing about, more detail than that. As I had assumed that consent was sought. And I've explained that I thought it would be difficult, particularly when partners are involved, to take samples. But I must be honest and say I have my doubts about that now. But without actual notes, it's difficult to say.
If the purpose of taking the samples was explained to a patient and consent sought, would that have been, and I'm talking now the period at 91 through to onwards, so when you're there, Would that have been done by a nurse or by a doctor, typically?
The vast majority of cases, undoubtedly the nurse. And indeed, the nurses, because there were a lot of patients to get through, as I told you, they went out to people's homes as well. But the nurses had the role of collecting the blood samples. Now, I'm not saying doctors didn't collect blood samples on people that turned up to clinic, but my clear recollection and impression is that the nurses were responsible for collecting the blood samples.
And do you recall any discussions you had with patients during this period in which you told patients you were going to be testing them for hepatitis C?
Certainly, when I have tested people for hepatitis C, I have always sought consent. And it's never been with pre-counselling, as I've said in my statement to the Lindsay Tribunal, and I wouldn't have written it down, if I'm really honest. I would have told, just put it in the notes that I was doing it. But I wasn't really involved in that initial round of the HCV, the formal study. I was not involved in that. My work, when I came, following on from the point we made earlier, I think most of my work when I arrived was actually, I was the one dealing with the wards which were much busier. I was doing the clinical stuff. Dr. Ritzer tended to stay in the Hemophilia Centre and deal with more of the admin and the that sort of thing.
And then in terms of when the test result came back, they're telling the patients that they had tested hepatitis C positive. What is your best recollection of how that was done?
That tended to be done when patients came for their follow-ups. So, or if somebody popped into the department. Now, I definitely was involved in telling some of the patients their results. Absolutely, I was involved in that. But my impression is, and my recollection is, that Dr. Ritzer and Dr. Trowell had much closer links with the patients at that time and were dealing with the patients. After all, Dr. Trowell, she was having weekly clinics, and reviewing patients every 6 months or every year. So you can imagine a large number of patients are coming through to her.
So a severe haemophiliac or another patient who had regular scheduled 6-monthly appointments would typically be told the hepatitis C result, as far as you understand, at their next scheduled appointment.
That's correct. So people were not told by letter, and there was no meeting that was convened to tell people about the infection. I think the view was it was a slightly different scenario than, say, the HIV scenario. Many of these patients had, after all, been infected. They were infected probably in the 1970s.
And then in relation to those patients who were not regular attenders, so did not have their 6-monthly appointments because they were mild haemophiliacs or infrequent bleeders, whether that was haemophilia von Willebrand's, what, to the best of your knowledge, were the arrangements for testing them and telling them the test result?
That really happened as a second wave, and I think I said this in the Lindsay Tribunal. The focus was undoubtedly in the period 1991 through to the end of 1993 to deal with a large cohort, which was well over 200 people that had to be counselled. But we did then try to track down as many people as possible to test them, and that, I will accept, went on till certainly 1995, 1996. I even remember, actually, because we kept our eye out, there was one patient, I was thinking about this morning, that we picked up years later. I remember the Skipton Fund had been set up, so we're talking post-2003, and after many years, he made contact with us, because I remember telling him the results and talking to him about the Skipton Fund. So I fully accept that there was a delay in arranging for the testing and informing the milder patients and indeed some of the patients with von Willebrand's disease. But we had a large number of regular patients that were informed first.
And when a patient was told of their result, I think you told the Lindsay Tribunal that at the time there wasn't any written material that was given to a patient with information about hepatitis C. What kind of information do you recall was given to patients, at least those patients whom you were seeing and breaking the news to them that they were hepatitis C positive?
Okay, there were two issues. Some of the patients, of course, already knew that they had some form of liver infection and they were under Dr. Trowell, so it really wasn't, shall we say, a surprise. I think the difficulty we faced right at the beginning was not having the PCR test result, because that was crucial. So in the 91 and certainly a significant chunk of 92, we didn't have the PCR result, which enabled us to distinguish between those with persistent infection and those who'd been exposed to hepatitis C but eliminated it spontaneously. So the advice would have been along the lines of, and some guidance, of course, would be provided by the liver function tests. If they'd been persistently normal, you might take a different view than someone who's got clearly had intermittent, at least, abnormal liver function tests. But they would be told they'd been exposed to hepatitis C, which perhaps they'd heard of as non-A, non-B hepatitis, and we would make it clear that we were following up and going to be doing regular liver function tests. And if the question of sexual transmission came up, by certainly the end of 92, it was clear from 3 published studies that the risk of transmission was low.
In terms of the stored samples, other than being used for the purpose of testing for hepatitis C, were they used after your arrival for any other purposes?
Okay, so the question of stored plasma, just to be clear, to set that out, I mean, it certainly was the custom and practice before I started and when I left to collect stored samples. And before I answer your question specifically, let me just say a little bit about that. There wasn't a systematic collection. It's not that we said, and you'll find no memo from me to the lab staff saying, I'm going to send you a separate tube, please collect this and put it to one side. It was really what was left over from clotting tests that we had done in our laboratory. And quite an archive was built up. Now, why was it started in the first place? I think clearly because there was some research interest, and I think I heard you allude to a Professor Zuckerman some time ago who'd recommended doing this. I think also in a haemophilia centre, we have to remember that factor VIII deficient plasma was a precious resource because you need it for factor VIII assays and inhibitor assays, and in later years we had to move for health and safety reasons. We had to buy it commercially because it had been screened for Hep C and HIV. So it was custom and practice, not only in the haemophilia centre, other departments within the trust, also other haemophilia centres. There are guidelines that are published on the storage of serum and plasma by the Royal College of Pathologists, and they recommend keeping plasma and for as long as practical, actually, practicable is the wording they use in the guidelines on storage and retention of plasma, for 2 reasons. Firstly, for future research, and secondly, it says for disease surveillance. And of course, the Royal College of Pathologists made clear in its guidelines that very specifically serum and plasma are excluded under the Human Tissue Act from a requirement to obtain consent for storage. But to answer your original question, did we use it for anything else? Yes, the samples were useful sometimes. We would pull them out if a patient came up for a review and they had an equivocal inhibitor screen, for instance. Yes, to give an example, we'd go back to a previous sample or even previous samples to see if there'd also been a similar problem. So did this patient have a fluctuating low titer inhibitor, just to give you one example. What I can say categorically is that although we stored plasma, and this was done, I fully accept, without the consent and indeed knowledge of the patients, we didn't do any serological testing for other pathogens, be it parvovirus or research other projects. And I can give an assurance that if you'd wanted to do, if a new test had come available for, let's say, variant CJD, I fully accept that patients would have to have their consent sought for such testing.
So
it's a long answer, I'm sorry.
Is this correct then, that the plasma that was stored, and I'm talking now about your knowledge of matters from April 1991 onwards rather than what may or may not have happened before, if it was used for purposes relating to the patient's treatment and management, albeit without them knowing that, are you able to be categorical that it wasn't used for purposes unrelated to the patient's own care and treatment?
I'm not aware, I must say this to you, that's the sort of wording I would use. I've certainly never initiated serological surveillance at all. You know, if someone comes up with a hepatitis X, you know, we've done nothing like that now.
And they weren't used for purposes of research?
No, not that I'm aware of at all.
Just going back to the checklist that you referred to, and indeed you told the Lindsay Tribunal about, you referred in your earlier answer to the point in time at which Dr. Ritzer was retiring. Was it around then, 1993, that you introduced the checklist, as far as you can recall?
Yes, I started before so if I had to, you would find the first ones in the notes from probably July, August of 1993. And just to be clear about, sorry.
No, carry on.
I was just going to explain the purpose of the checklist was, and the only people who went through the checklist, they had to be doctors. So we talked about the nurses taking blood samples. It didn't have to be me. It could be either the other locum consultant who joined us afterwards, or the junior doctors. It was, you know, we went through the story. I told them what to say, and it was a record that was put to the notes. It wasn't signed by the patient. It wasn't hidden from the patient, but it was primarily to be a record for the clinical staff of the Haemophilia Centre, not just to understand whether patients are being told about hepatitis. Actually, you know, their HCV result, what they had actually been told by people.
You say it wasn't hidden from the patient. As I understand your evidence to Lindsay, it wasn't, as a matter of fact, shown to the patient or shared with the patient either.
That's correct. But it would have been on the desk when I'm writing with it, and the patient will be opposite or next to me, and they would have seen it. But I would fully accept. I never said, by the way, here's a hepatitis C checklist. But it was not hidden from them, but it was equally true to say they were not shown the checklist.
And then there's one further document on hepatitis C testing more generally. It is DHSC 0004294_002, please, Shomek. Now, this is not an email to you, but it's an interdepartmental Department of Health email from Charles Lister, who was an official within the Department of Health, to others within the Department of Health. And it says this: Dr. Giangrande gave me the following comments by phone. This is a summary of what he said from my notes and has not been verified by him. Throughout the 80s, doctors and patients were aware of the potential exposure to non-A, non-B, but there was no test. In 1989, the hepatitis C virus was discovered. Throughout 1991 and 1992, the first testing for hepatitis C was applied to haemophilia patients in the UK. Patient-stored samples were generally used. This was a much to test the test as to test the patient. There was a time lag of 1 or 2 years in telling patients because no one was sure until then what the results meant. However, he was confident that patients would have been aware that tests for the virus were being done. And then there's a reference to the reliability or otherwise of the early hepatitis C test. Now, I don't know whether you have any recollection of a discussion of this issue with Mr. Lister.
I don't, and to be honest, I'm a bit surprised that someone from the Department of Health phoned me. I'm not sure why they would have, what that was about. It could have been, and I hope we're going to talk about this later, the Haemophilia Society Hepatitis C report.
I think if we just go to the next page, we might see a little more about the context.
Yeah.
It looks as though it was the context of it was Lord Morris had asked Department of Health ministers to look into allegations of testing without consent.
I see. Okay. Well, in that case, it's very that's really interesting, because I have to say, if we go back to the previous one, clearly now my views have changed. I don't believe that. Could we just put
yes? Can we go back to the first page, Seamus?
I mean, clearly this was a broad generalisation, but I'm afraid I can no longer say that I'm confident patients would have been aware that tests for the virus were being done. Now, of course, like a lawyer, one can read that sentence now, I think about it in several ways, that patients knew the test was generally available and that there were tests being done. But I take this to mean that I was saying patients were aware that tests were being done on them for hepatitis C. And I'm afraid I can no longer say that with confidence. I've read the many statements. I'm sure some were, but I'm not. As a generalization, I don't believe that to be true.
Can you actually remember having that view at the time?
So, Brian, the honest answer is as I said when we were talking about my evidence to the Lindsay Tribunal, I think what gave me that impression was the fact that the sexual transmission study, I just assumed that patients had been told and their partners were told that the test was being done. I thought that was a reasonable assumption. But
so the answer is yes, you did think that. You have changed your mind. You thought that because it was a reasonable assumption to make.
Yeah, yes, I have changed my mind, yes.
So the assumption was that everything was being done as it ought to have been done, if I put it in those terms.
Yeah.
I want to then come on to the arrangements for care and treatment for hepatitis C and monitoring liver function and progression of liver disease. We know already of the clinics under Dr. Trowell, and you've made reference to them. In 1991, when you arrived, were those undertaken as joint clinics, or were they clinics held by Dr. Trowell and her team?
They were held by Dr. Trowell, and she didn't have a team with her. I mean, she obviously had a team, but they were based over at the John Radcliffe Hospital. But she ran those clinics alone. And we did not sit in with her at those clinics. And to be honest, what we tried to do was the patient would see her, and then if they were coming for their 6-monthly follow-up, we would do that. We would coordinate it that way. So, no, as a general rule, we did not sit in with her. But obviously, she's in the building with us. We would, not in such a coordinated way as with the HIV team, we didn't sit down and have a separate meeting, but this was an opportunity to exchange news and information about individual patients.
And in terms of decisions on treating patients in the early days with alpha interferon and then with pegylated interferon, ribavirin, etc., did you or the Haemophilia Centre have involvement with those decisions, or were those matters that were solely dealt with by Dr. Trowell?
They were solely dealt with by Dr. Trowell, but I would say sometimes I would write her a letter, and I would actually, I like when I write a letter to a colleague to pose a specific question. Is this person a candidate for interferon therapy? So I would pose the question if the patient is not already followed up, and she would provide the answer to that.
I'm going to ask you to look at some guidelines on the diagnosis and management of chronic liver disease, which you've exhibited to your statement. Shomek, it's WITN 3311008. So we can see from the top of the page, these are published in 1995. They're guidelines on the diagnosis and management of chronic liver disease and haemophilia. And it's co-authored by Professor Preston, Professor DeShaco, Professor Lee, Professor Ludlam, and yourself, comprising the Working Party on Chronic Liver Disease and Haemophilia on behalf of UK HCDO.
Yes.
And if we just look at some of the broad guidelines that were here set out, we can see if we go, well, in the first paragraph, it talks about virtually all haemophiliacs treated with clotting factor concentrates before 1985 have been exposed to hepatitis C virus. Almost 100% of these are HCV antibody positive. And then there's reference to the propensity to cause chronic liver disease and hepatocellular carcinoma now emerging as a complication of chronic HCV infection. If we then go down 2 paragraphs, please, Shomek, to beginning the working party. So third paragraph. The guidelines say this: the working party wish to stress that wherever possible, close collaboration should be established between the Haemophilia Centre Director and a consultant hepatologist, and that the latter should play an important role in the management of haemophiliacs with chronic liver disease. The patient should be kept fully informed of the results of all laboratory tests, including antibody status. The clinical implications of the findings should also be discussed. Then under the heading Diagnosis of HCV infection, there is a recommendation that all patients who've been treated with blood products should be tested by a second, third generation HCV antibody test. And then we can see the bottom of that paragraph talking about decisions with respect to treatment with interferon should be made through consultation with a hepatologist. We go to the next, top of the next column, please. We can see under the heading Sexual Transmission of HCV, there's an estimate of the risk, less than 3%. And it said that the current data on the rate of sexual transmission and the advantages of barrier contraception should be discussed. Patients should be encouraged to take a joint decision with their sexual partners. We can then see in the next paragraph that it's recommended that HCV testing should be offered to all sexual partners of HCV antibody positive patients. And then we have recommendations for follow-up. So if we scroll down the page a little, please, thank you. So point 1 is HCV infected patients known to have abnormal AST or ALT levels should attend for review at approximately 4 monthly intervals. And then there is further recommendations of as to how to determine ALT and AST levels in paragraph 2. And then if we go to the bottom of the page, there is a paragraph headed Treatment with Interferon Alpha. We go over the next page. To top of the second page. No, it's the page before that. Don't worry. That's it. So if we just, thank you. We can see there's then a discussion about response to interferon, and then the second paragraph says, with this background, the working party wish to make the following recommendations. And then we see a recommendation for consideration of treatment with interferon for patients with biochemical and serological evidence of chronic HCV-related liver disease. There's reference then to genotypes and determination of genotypes. And then if we go, we can see, in fact, in the right-hand column, role of liver biopsies, the specific recommendations about when liver biopsies should be considered. And then under the heading Other Investigations, we can see recommendations for endoscopy every 5 years for patients over the age of 45 and or those who've been infected with HCV for 30 years. And then there's a suggestion that this interval could be reduced in patients who are co-infected with HIV. And then a reference to abdominal ultrasound for patients over the age of 45 as part of screening for hepatocellular carcinoma, and specific recommendations for ultrasounds and alpha-fetoprotein determination for patients known to have cirrhosis at approximately 4 monthly intervals. And then finally, we can see a discussion about advice on alcohol consumption, and on the final page, a discussion about circumstances in which liver transplantation may need to be considered. Now, as far as you're aware, were those guidelines followed at Oxford through the liver clinics by Dr. Trowell and her successor?
Yes, and just to say, I think all those important topics were indeed the headlines of my HCV checklist. As you know, it's interesting that they are the same things. Yes, I mean, broadly speaking, in terms of follow-up, the average patient was seen every 6 months rather than, say, 4 months. Some were seen, the threshold for seeing Dr. Trowell was quite low, actually, so some patients were followed up on a yearly level. She certainly offered endoscopy. We certainly offered, the alpha-fetoprotein test was done, and we didn't do ultrasound, but these are things which, broadly speaking, she did cover. She was not enthusiastic about the use of interferon, I must say, and I think perhaps older and wiser, I think probably she was right, because the side effects are severe. But we didn't have many patients who were put on interferon in the early days. We did do genotyping, and genotyping came in probably, we were not one of the first centres to introduce it, so I would suggest 93, possibly even 94, and I know that genotyping was used to select or exclude patients. It was weighed up in the balance. So broadly speaking, I think that covers very well the follow-up of our patients in Oxford.
Now, Oxford was, as you told the Lindsay inquiry, one of the few centres that was in the unusual position of having long-standing established links with a hepatologist through the arrangements with Dr. Trowell. And I think in your Lindsay evidence you referred also to Sheffield in that respect.
Yes, I did, yeah.
What was the purpose of the UK HCGO and the Working Party in producing these guidelines? What were you trying to achieve?
I think really UK HCGO produced guidelines in a whole range of areas, so all areas of haemophilia care, from genetics to how to manage inhibitors. And I think the idea was to tell all haemophilia centres, and we've got some real experts on that panel there, Jeff Dusheko from the Royal Free Hospital and Eric Preston, what should be offered to patients with haemophilia in all centres. It was to set a sort of a standard. Now, and I think review the evidence as well. I think the evidence and the cited literature is all very useful.
Now, the inquiry has heard evidence of very variable practice nationally in relation to the care of patients with hepatitis C in the 90s and onwards. Do you know whether the Working Party on Chronic Liver Disease and Haemophilia monitored whether these guidelines were being implemented in haemophilia centres across the country?
I mean, the Working Party certainly didn't, but I would imagine that Eric Preston, who was very active as a speaker and at various meetings, and also Jeff Dusheko, I'm sure they would have promulgated them themselves, but it was never a role of the Working Party. Having said that, now I think about it, you may know that haemophilia centres have always been subject to audit. I forgot when the audit process came in, but one of the purposes of the audit, one of the things on the checklist of the audit was to check that people were following guidelines, although now I think about it, that really only applied to the comprehensive care centres. So I think you're talking about the much smaller centres. So the answer to that must be, now I think about it, there was no way of following up to make sure smaller centres were following these standards.
Now I want to move to the question of arrangements for the purchase or procurement of blood products and treatments for patients with bleeding disorders. When you arrived in 1991, you've described in your statement that for the period from then till around 1995, your recollection is that the products that were used at the centre were factor 8 and factor 9 concentrates from BPL.
That's my recollection. Certainly there wasn't any, I don't remember any tendering process at that period. I believe we just got factor 8 and factor 9. We'd pick up the phone, there was no budget that I was managing, that's correct. And then that was followed by a period in which we definitely had a formal procurement, and that was run by the trust. And then the third and final phase, that started in 2004, and I retired in 2015. That was at a purely national level, and I think others will have spoken about that, in which I had no involvement.
So just dealing first of all with the 1991-1995 period, and I've assumed, please correct me if I'm wrong, that all the concentrates that were being used at Oxford would be heat treated.
Yes.
Other than receiving concentrates from BPL, do you recall any approaches from commercial pharmaceutical companies in that period attempting to persuade you to use their products instead?
There may have been in terms of the high purity products. I'm thinking of Armour, Monoclate P. I mean, clearly, if we look at the annual returns, we'll see that. But a hot topic in the period of 1989 to 1994 was the question of high purity products, particularly for the HIV positive patients. And I think the only circumstance in which that could arise that we were approached would be in relation to that, because BPL was not the first company to produce high purity products.
And do you recall whether you decided to use high purity products in that period?
I can't remember, but clearly the annual returns will show that very clearly.
And then in terms of the period which you've identified in your statement as being from 1995 to 2004, when there was a tendering exercise run by the Trust, what was your role as Centre Director and Consultant Haematologist in that exercise?
So the Trust would run the procurement, and because of the volume, it had to be advertised internationally as well. So what would happen is we would, it wasn't just me and David Keeling and our manager, we would meet up and we would set out the sorts of products we wanted, and the brand would then be decided by the procurement. So if we say we wanted a high purity factor 9 product, or we wanted a recombinant albumin-free, that sort of thing.
Okay, so you would say to the Trust the type of product you wanted.
Yeah.
Is this correct that you wouldn't specify the manufacturer?
Correct.
And that would
that
then
had
be
to be put out. That would be put out to advertisement. That's correct.
In terms of prophylaxis, your statement estimates that was introduced in 1995 or thereabouts.
I think that's about right. That's about right, because firstly, of course, the confirmation of viral safety of 8Y only came in, I think, 1993. But my recollection certainly is that we had a lot of patients in the orthopaedic centre, the neighbouring Nuffield Orthopaedic Centre. There was actually a children's ward, and every day there would be patients on that ward. And indeed, we had in those days a Friday ward round with Professor Robert Duffy, who was the head of the Nuffield Orthopaedic Centre, who also, fortunately for us, he had a principal interest in haemophilia. So I think that's right. Prophylaxis started in the sense of prophylaxis for general regular treatment, twice or 3 weekly times a week, started in around 1995.
Now, part of your responsibility as Centre Director at Oxford for a number of years after you arrived was the management of the database that was still then at Oxford, and the evaluation of the annual returns and so on, which you undertook, I think, for a number of years with Miss Spooner. Can you describe to us what that entailed on your part?
I'm really honest. Rosemary Spooner really did most of the work, if I'm really honest. So the data would come in to her, and Miss Spooner would be prepared, if necessary, to go to other haemophilia centres actually to collate data. She's been known to do that. And a report would be generated. It was always on an annual basis rather than a financial year. That changed later on. And at about October of that year, or September, October of that year, a report would be drafted up. It was, if I'm honest, somewhat formulaic in the sense that you could take the previous year's report and sort of add on. So in other words, there would be a breakdown of the products used. There would be a graph to which you'd add another point showing, what was the factor consumption in, say, 1993. And there'd be a commentary on the product usage. So it was a simple report. And I think the subsequent reports were much more sophisticated and complex. But I think it was a very useful report. It was a somewhat formulaic report, I would have to say.
I'm going to ask you to look at one example. In fact, the 1993 report. Seamus, it should be HSOC 0024849. I hope. Yes. So we can see this is annual returns for 1993, and it refers to attached tables and graphs. returns requested from 107 centres, received from 102 centres, some queries outstanding. And then we can see in the second paragraph it gives information about numbers of patients with haemophilia A, with Christmas disease, as it was still then being referred to, with von Willebrand's disease. And then we can see under the heading treatment of patients, there's a summary of numbers receiving therapy, including home therapy. If we go over the page, we can see that the first two paragraphs give further summaries in relation to units of different types of products used. And then we have reference to Table 8, giving an analysis of the causes of death. And I just wanted to ask you a little bit more about that, if I may. So it says Table 8 gives an analysis of the causes of death in the 110 patients with haemophilia A, 6 with Christmas disease and 10 with von Willebrand's patients who died in 1993. AIDS was the commonest cause of death, 47%, with cerebral hemorrhage and liver disease, 10% joint second. There were 9 cancer deaths, including 1 case of hepatoma, and 7 patients died from heart disease, 6 from pneumonia, not PCP. Cause of the deaths of 10 patients was not known. And then further details in relation to deaths of patients diagnosed as having AIDS in Table 9 and Table 10 showing the HIV status of the patients known to have died. So we can see from the report part of the purpose of it was to summarise the information about numbers of patients and type of treatment. What was the particular purpose of the gathering together the data on causes of death?
It was of interest, and if you look at previous annual general meetings, people wanted more, they wanted this sort of information, and I think it's relevant to include it.
And if we just go to Table 8, Shoma Kits. I think it's probably page 10. And can we turn it round so that we can view it properly?
It is all right. If you can't, I can turn my head. So you tell me what you want.
I'm thinking also of those who are watching. Can we turn it?
I can read it. Please don't trouble yourself. I'm fine. I can read it.
Well, just take it slowly so that those who are watching at a distance can turn their heads and follow it.
So if we see in relation to AIDS, which is the first column, we can see that there are 3 categories of patient, and would I be correct in understanding that broadly correlates to severe haemophiliacs, moderate haemophiliacs, and mild haemophiliacs?
Yes, it's interesting to note, by the way, at this stage we were defining severe. It may be of relevance discussions you may wish to raise later about other matters. Severe was defined as less than 2%. From 2001 onwards, we switched to a definition of less than 1%, but it's interesting to see it still in the UKHCA returns as less than 2%. But that's right, severe, moderate, mild.
And then we can see in relation to severe haemophiliacs, thank you.
Yeah, thank you.
That makes life easier for everybody, including you, Dr. Giangrande. We can see two severe haemophiliacs have died in the age range 10 to 19, 12 in the age range 20 to 29, 17 in the age range 30 to 39, 7 in the range 40 to 49, 9 aged 50 to 59, 2 aged 60 to 69. And then we can see that in terms of those with moderate haemophilia, again, 2 deaths in the age range 10 to 19, 3 20 to 29, 1 in the age range 30 to 39, 1 40 to 49, and 1 50 to 59. And then in terms of mild haemophiliacs, 1 death in the age range of 30 to 39, giving us the total we see there of 59. Now, this obviously is a snapshot, but a snapshot of a particular year. What kind of data on death and causes of death was this analysis based on? What information did Ms Spooner and the centre have access to?
These data, of course, formed the germ of several much more sophisticated analyses, including our report in Nature in 1995, and very specifically an analysis of age as well, which we published in the Lancet. So the impact of age at the time of infection on the progression of HIV. As regards the source of the information, this was predominantly from death certificates. And in 1988, so before I came to the Haemophilia Centre, UKHCDO set up a system which I understood from Professor Hayes' transcript is still in operation. And that is, people on the national database were flagged up by the Office of National Statistics, and copies of death certificates were automatically sent to the Secretariat, showing the, so if someone died, the death certificate would be sent, and it was paid for, to the Secretariat. Now, in the studies that we will talk about later, like the Nature 1995 one, we went a little bit further. I see on the left of this, there's AIDS and 2 asterisks. And I'm going to ask you if there's any, what that note refers to. Is it saying it's just from death certificates or information from centres?
No, if we go 2 pages further on, we can see what it is.
I'll just tell you the reason I'm saying that, because very clearly, and this was an issue we specifically addressed in the Nature 1995 paper, many people, especially in the early days, were very reluctant to see AIDS on a death certificate, because these are public documents. Anyone can ask for a death certificate. And so sometimes it would be disguised, say, pneumonia. And so one of my roles in the 1995 paper, I can tell you for certain, it was 168 patients. We say that in the 1995 paper. I wrote to haemophilia centres and along the lines of, dear colleague, we've got a report on this man. Could you tell me, was this actually HIV related or not? So what I'm not clear, so for the Nature paper, we had those 2 sources of information. What I'm not clear looking at this table, and I say that's why I was querying about the asterisk, is just death certificate information. I think this is reports from haemophilia centres. I think this is filling in a death form.
Okay. Shall we have a look at the...
yes, the double asterisk doesn't actually give us the answer. If we go on 2 pages, please, Seamus. And if we can switch that.
Okay. Yeah, okay, I can see that.
The double asterisk says see table 9 for further details. Okay. And if we go on to table 9... Yeah.
So, what I would say is clearly...
If I may just interpose, you're speculating at the moment about the source of information.
Yes.
There is a clue, I think, in the part of the description at the start of the report, where it talks about the causes of death. That paragraph that deals with it, where it talks about some centres not having been told or not having identified the cause of death. So it looks as though the information comes at second hand from the centres, wherever they may have got their information. That will be the inference which, at the moment, I think I would draw from this material. But I may, of course, be wrong, and it's only a very narrow basis so far.
And just so that others follow, because others won't have the document, if we go on 1 further page, Seamus, we can see that table 9 is a breakdown of the different conditions of the deaths of the patients who had died during 1993. So it doesn't tell us the source.
Can we have a look at cancers under that? Is there a detail there?
No. So if we go over the page to table 10, there is information there about the HIV status of patients known to have died. in 1993, and there is there a reference in terms of cancer to one patient being HIV positive, 4 negative, 4 not known. So there may, of course, have been AIDS may have contributed to other deaths. Dr. Giangrande, is that a fair assumption?
Yes, I'm sure that is true. I mean, I quite take the point about speculation. Obviously, it's a very long document, and to suddenly take this all in and give an answer is difficult. What I would certainly say, though, is that the Nature 1995 paper and subsequent ones are more reliable. I think I can say that categorically, because those are using data from death certificates plus information supplied by haemophilia centres. So if I were to use a source, if I wanted to consult a source for information on causes of death, this is useful, but it's not as good as the more formal peer-reviewed publications. Is that a fair summary?
Thank you.
Right.
So I note the time.
Yes.
I'm happy to break here.
Well, we normally have a break for an hour at this stage to allow us all to have the refreshment that normally comes in the early afternoon. So let's do that now. The same rules apply, of course, and I shall see you back here at 2:05. 2:05.
Thank you.